Hey everybody, my name is Todd Brookens and I'm an emergency room physician here at Toledo Hospital. And I've been asked to go over some airway devices that we have in the ER that you need to be familiar with. And let me first start by extending a warm welcome to you, to all of our new employees. We're very happy to have you. It's an exciting place to work and I think you'll have a great career here. There's a lot of information to know, and just take your time getting used to everything and ask a lot of questions. We're all very approachable and should be able to help you out. So my passion is airway emergencies. I also really enjoy EMS, so I work closely with EMS in our community, but I really like airway emergencies. So thankfully, the chance that you're going to have an airway emergency in the emergency room is pretty rare. But we have tools here that you need to know where they are and how to get into them and how they're used to help the doc out in an emergency. Don't assume that respiratory therapy is going to be there when you arrive to the patient's room. They may have a vented patient in CAT scan that just came in as a race alert, a stroke alert, and someone's tied up on the floor. So don't assume that they're going to be there, and we'll just call respiratory and they'll bring all the stuff to you. So we want you to know where things are so that you can help out in a pinch. So the first issue with any airway emergency is go back to the basics. Make sure that you have everything ready to manage the airway. A bag valve mask with an appropriately sized mask, and that you have an oxygen source, preferably two if you have them. So make sure you have a mask and a bag valve mask. Positioning is also key. Notice how we have the patient positioned in a head elevated position and doing a jaw thrust. Having one person dedicated to doing a jaw thrust like this while the mask is applied is going to be really important. Just like this. That can help give yourself some time, buy some time when you have a patient that's going sour. The other thing is to use airway adjuncts. Simple things like a nasal airway or two nasal airways. Just open them up, pop them in the nostrils, and that can really help to open up the airway and allow you to ventilate the patient a lot easier. Oral airways can help as well, but the patient can't have a gag reflex, so make sure that they don't have a gag reflex. Put the oral airway in, nasal airway, put the bag, have a good two-handed jaw thrust technique, and then gentle ventilation. All right, so most of the time we are able to intubate the patient with this device. This is a video laryngoscope called the glide scope, and it's got a disposable end here, and on the end is a light source. It's very bright, and then on this part is the screen where we can see what we're doing. So you will see a majority of our doctors using this type of a device. For the most part, we've gone away from the direct laryngoscopy with the straight or the curved blades. All right, so I'm just going to show you kind of what this would look like after the patient's asleep, and this is inserted into the airway, and then lo and behold, with proper manipulation, you can see the glottic opening right there, and then the tube would be passed through there. So now let's say that things aren't going well and you're having a hard time getting the patient intubated, but you can still ventilate them. Or you get to the point where you can't intubate and you can't ventilate. That scenario right there, can't intubate, can't ventilate, is a very dangerous situation. Most of the time those people need what's called a cricothyrotomy. So that's where this cart right here to my left comes into play. This cart is kept in room 25, back in the corner. It's called our difficult airway cart or bronchoscopy cart, and these come from Central Supply. So once you're done with them, they need to be sent down there and restocked. I'm just going to go over the parts of the cart here. On top here is just a canister that you put your fiber optic scope in when you're done. So that goes in there. On top here, we have the light source for our bronchoscopy scopes, which are in this part. So this does have to be plugged in. In order for the light source to work, you have to plug it in, so you have to be close to a plug. And the on-off button is right up here. Also on the top shelf are 3 disposable laryngeal mask airways. 3, 4, and 5. Those are standard. So those are great rescue airways, supraglottic airways that can be slid in easily. You can ventilate the patient through them, and it can buy you some time. Also on the top shelf is called the lighted stylet. This has a flexible stylet that the endotracheal tube can go over, and then there's a part on the end where you turn it on and it will really light up the airway for you. Don't really use this very often, but it's there if you need it. All right, so that's the top shelf. We're going to go on to the second shelf now, and this has syringes, some neosynephrine, some lidocaine. 4% lidocaine is here. Sometimes for an awake intubation, we want to anesthetize the airway, and we give them a lidocaine aerosol, and that's what 4% lidocaine is for. Other topical anesthetics here, Topex, which is, I think it's benzocaine. Yep, benzocaine. And then lidocaine jelly. The other device that's important here is this little fiber optic bronchoscope swivel adapter, and I'll show you how that works later, but that's on the top shelf, or second shelf. On the next shelf down, we have a bite block. Put in their mouth if you're going to be scoping them orally. Looks like this. It just fits right in their teeth. What else do we have here? Another different kind of bite block, that larger size, fit a bigger tube down. And then some bronchoscope adapters here. This one in particular is important if you need suction. And I'll show you how that hooks up onto the bronchoscope as well. And then on the bottom shelf are various airway devices. Specifically, this device right here, which is called an intubating LMA. And this is not disposable. You don't want to throw this away. This is reusable. And it has its own proprietary endotracheal tube that goes down the middle once you have this in. And you can intubate through that. Now the point of this is, just like the other LMAs, it's supraglottic, it's above the cords. It slides into the mouth like this. If you have a difficult airway, it has to be lubricated up. Slides right in and seats at the glottic opening. Then you can inflate the cuff on the end and hook your bag valve device up and ventilate the patient. Gives you some time. Then when you're ready to intubate the patient, you can take their proprietary endotracheal tube and slide it down, usually right into the cords. And then in order to get your device out, your LMA out, you have to have this holder, which goes right in the endotracheal tube, and then you begin to slide the LMA out and grab onto it. And your device is in place. Hook the bag valve up to the tube and ventilate the patient. You have an airway. So these are all bridge devices, and in a panic, in a pinch, in an emergency, it's something quick that can go in and ventilate the patient. All right. So other devices that are in here besides the intubating LMA are Crike kit. This is a Cook Crike kit. It's a Seldinger technique. It goes right through this part in your cricothyroid membrane and has a wire in it. So really nice device if you get it to work okay. So that's there. Some endotracheal tubes are in here. And some saline, some masks, and a different kind of new trait cricothyrotomy kit. So, one last compartment is on the side. People often forget there's some important tools in this. It says it used to be locked, but it's not locked anymore. All you have to do is pull hard. So you really have to give it a pull to get it open. All right. There are 2 bronchoscopes in here. Oh, no, I'm sorry, just one. This is the standard adult size bronchoscope. So I'm going to show you how you set this up. Pretty darn quick. This part right here goes into the light source that you've already plugged in. Just plugs right in and you turn it on. Once you have it on, your light source is right there, and the end can be flexed by the operator. Now, if your operator wants you to have suction, then you hook this suction device right onto the end here. Yeah, right there. And then your suction device goes through here, or oxygen. You can actually hook up oxygen to this too, and entrain oxygen through the end. Okay? Now, oftentimes the doctor will want to try and nasally intubate the patient with a fiber optic scope or orally. Some doctors feel comfortable doing this, some don't. Anesthesia may, however, come down and want to use this device. I would say in my practice, I do this maybe 2 to 3 times a year with a fiber optic scope. And the main cases are patients with upper airway obstruction from angioedema, where their tongue is coming out of their mouth and you can't get the glide scope down. So those are ones you would do an awake fiber optic assisted nasal intubation. And so this is the technique where you put the tube down, use the scope to see where you're going, and then you, once you're where you need to be, you pass the fiber optic scope in, and then pass your tube over it. So this is the fiber optic scope. Usually the patients have to be in an upright position, and you stand at the side of the bed, and then you help pass a tube over into the trachea. All right, and another very important device that is in this that is often hidden is the bougie. This is called an endotracheal tube introducer sheath, also known as the bougie. And this is a wonderful device. It's flexible, and basically what you do with it is you can load your endotracheal tube on it. Make a little hockey stick on the end. And then if you're having a hard time finding, say you get in here and you know where the cords are, but you can't see them very well, use this device to feel your way into the cords and then pass the tube through. It's hard to do with a scope. So usually you have to use it with a regular laryngoscope. But this is a really important rescue device called the gummy elastic bougie. We also have some of these in the respiratory carts, I believe, and they're blue. So you may see these as blue with little black markings on them, but this is another one that's kept in the cart. And it's in this little plastic sheath, and it's easy to not see in a panic, but that's where they're kept. They're always kept there. So gum elastic bougie. All right. The last thing I want to go over is our RSI box. These boxes are kept in all the crash carts in the top drawer, and they're in the trauma rooms, in the Pyxis in the trauma rooms, in the bottom drawer. For those of you that aren't familiar with rapid sequence intubation, RSI is a technique we use where we rapidly give a potent anesthetic and a rapid onset paralytic muscle relaxer. If you've worked in anesthesia or in the operating room, they often don't use the same technique we use because those patients are different than ours. Ours are assumed to have a full stomach, every one of our patients. They're drunk, they're full of pizza, they are full of beer, they may be full of blood. They're patients that are not NPO. So in that situation, we want to rapidly paralyze them and rapidly sedate them all at the same time. So it's a potent sedative and a potent paralytic given at the same time. So a lot of doctors do it differently. I would say the standard that we use is a combination of etomidate or amidate and succinylcholine for most of our adult intubations. So your drug box has all the things that you would need in it for that. I would just let you know that there's a new regimen coming out too where we're using ketamine. Ketamine is also a potent sedative, and then in addition to that we're using a paralytic called rocuronium. So your doctor may ask you, let's drop 1 milligram per kilogram of ketamine and a vial of rocuronium. So the other short-acting paralytic is succinylcholine. It has the red top here. And this lasts about 7 minutes, whereas rocuronium or vecuronium lasts about 20 to 30 minutes once you give them. So etomidate is this, comes with a blue cap on it, and a typical adult dose is somewhere around 20 to 30 milligrams IV. Additionally, you have some sedatives on here, some Ativan and Versed and sterile water and some syringes. So that is RSI. So just to recap, whenever there's an airway emergency, make sure that you take a deep breath, step back for a minute, try not to panic, know where your equipment is, and know where the basics are. Have a bag valve mask. Make sure your rooms, when you set them up in the morning, have bag valve masks, suction. Suction is key because they're all going to vomit if you're not careful. That you have airway adjuncts, basic airway adjuncts ready, and you know where to get them in case you need them. Most of the practitioners are using the glide scope for their intubations and know how to find that device and how to set it up. And then know where your difficult airway cart is, and specifically what, you don't have to know every single thing and how they work, but know where an LMA is, top drawer or bottom drawer. Know where the fiber optic scope is, side compartment. Know where the gun elastic bougie is, side compartment. And then know the common drugs that we use in RSI. Commonly, paralytic, succinylcholine, common sedative, etomidate, newer ones coming out, ketamine and rocuronium. So I wish you all the best. If you have any questions, we are here to help you succeed. We want you to succeed. So it can be a bit overwhelming, but we have an excellent education staff here. And so good luck to you all. Thank you.